Good morning. Today we are having a session on operative surgery. The topic will be right hemicolectomy. Dr. Nitesh Kumar will face the exam. And today our faculty is Professor Umunnu Basu, who is Professor and Head of Surgery at IPGM and SSK Hospital. So Nitesh, Dr. Basu will keep on asking you as it goes in the exam scenario and keep on answering. Okay, right hemicolectomy. Dr. Basu, you can start as it goes in the exam.
Yes. Nitesh, please.
Sir, today's session is operative procedure on right hemicolectomy. The indication for right hemicolectomy.
Share your screen.
Screen. I don't have, sir, any presentation.
No, he has not prepared screen. He will answer as you keep on asking.
Okay.
And steps, because if he prepares presentation, the answer is made with him.
Okay.
So if asking question as you ask in the exam. Indication, fine. Nitesh.
Sir, indication for right hemicolectomy the benign causes, that is ileocecal TB. Then, sir, cecal diverticulosis, cecal volvulus. Then, sir, adenomatous polyp in the right colon. And then, sir, malignant causes are malignant tumors in the ileocecal region, ascending colon, and hepatic flexure.
The important benign condition, rather benign come malignant. Benign could be a malignant. This is the IBD. You don't miss IBD.
Yes,
Inflammatory bowel disease.
Yes, sir.
Both Crohn's colitis and ulcerative colitis.
Yes.
Okay.
Yes, sir. Sir, then, sir, diagnosis, sir. Sir, it is.
No, you need not to say diagnosis. You said the indications. Now let the examiner ask the next question.
Now you say the preoperative preparations.
Sir, preoperative preparation, sir.
For a ascending colon carcinoma.
Sir, preoperative preparation, sir, will sir, diagnosis to be confirmed before by the colonoscopy and biopsy, and CECT whole abdomen for staging, and sir, then adequate mechanical bowel preparation.
Just wait. Whenever you say that the carcinoma of the GI tract, you must say like this, particularly colonic cancer, you have to say the full length colonoscopy. This is very important. You have to assess the full length because of synchronous malignancy. So in case of right colon malignancy, if your gastroenterologist or colonoscopist cannot reach the up to cecum, he or she may stop due to stenotic growth at the hepatic flexure. You don't need to do the full length colonoscopy or other thing because you are removing that part, the unknown part. Number one. Number two, whenever you say the CECT abdomen, you have to mention also the CECT abdomen and thorax. This is the standard NCCN protocol. And also you have to say the CEA. These three are very, very important. Then you go for the mechanical bowel preparation or other things like that. Okay, these are these three prerequisites. We are not discussing about the general investigation like total blood count and LFT and all those things. Okay, these disease specific three things are very, very important. Now, what do you mean by mechanical bowel preparation?
Sir, mechanical bowel preparation, sir. Sir, like before procedure, sir, the bowel should be cleared, sir. By using.
Why do you need an empty gut? Why do you need an empty gut during surgery? What is the idea behind?
Rationally behind?
Sir, empty gut is required because, sir, while doing resection anastomosis, sir, the spillage of the bowel content may lead to.
Here, bowel content is fecal matter. In the colon, the bowel is fecal matter. So you don't want fecal contamination. And second is what? What other effect is there on mechanical preparation? If you keep on washing the bowel, what happens with the washing apart from clearing the stool?
Sir,
What about bacterial count?
sir, bacterial count, sir, it will decrease, sir.
Yes.
So so remember, as the second point mentioned by Professor Saha, is important that you don't tell only mechanical bowel preparation. You have to tell mechanical bowel preparation with oral antibiotics.
Yes.
You read after this discussion, you read the Nichols-Condon regimen. You have to remember, because only bowel preparation has got no good effect on the anastomosis leak or the wound infection. This is very important. Though it is controversial, still most of the guidelines, they recommend the mechanical bowel preparation with oral antibiotics. And remember, in oral antibiotics, because Nichols-Condon regime is old enough, so now we replace the erythromycin to this thing metronidazole. It is better and for anaerobic. And number two, whenever neomycin is not available, we can use the rifaximin. These 2 points. You read yourself by the Nichols-Condon. I will not discuss here. So mechanical bowel preparation is important, and the how to do mechanical bowel preparation is very, very important. Okay. So next.
So next, sir, perioperative broad spectrum antibiotics to be given, sir.
What broad spectrum antibiotic you prefer?
Sir, the third generation cephalosporin, sir.
Okay, accepted.
And also you should add a aminoglycoside and metronidazole.
Yes, sir.
If the renal function is okay, yes, aminoglycosides and metronidazole is important. Yes. Then, when to give the preoperative antibiotic? This is important again.
Sir, preoperative advice should be given.
The timing is very, very important.
Standard recommendation. When do you give the antibiotic?
This comes under the checklist.
Sir, antibiotic should be given during the time of induction of anesthesia, 30 minutes before the incision.
No. It is a checklist. It is standardized that within 1 hour. That means 1 minute to 59 minutes, right?
Yes.
Within 1 hour is now accepted.
Accepted, not half an hour. Yes, preoperative antibiotic you have given. What anesthesia you prefer?
Sir, anesthesia is a general anesthesia with endotracheal intubation, sir.
Okay. So now the patient position?
Sir, patient position is supine. Supine position, antiseptic cleaning and wrapping is done.
Straightway supine position you will be comfortable, or some modification?
Sir, right up position will be more comfortable.
Little right up may help. Yes. It may be supine, but little right up may help.
See, okay. we are discussing the open right hemicolectomy. So the position, you may get some advantage if you do. This is the Trendelenburg position, mild Trendelenburg position with left side tilt. That means right side up. When you start section from the cecum, and when you go to the the hepatic flexure, then the position will be changed, reverse Trendelenburg position, right? So this is the 2 modification you can do in supine position, but these 2 modification can help you better dissection and visibility. Okay, incision.
Sir, incision is given, sir, midline incision from the mid epigastrium to the.
Incision is not given, Nitesh. Nobody gives incision.
Yes. This is term is very important. You are a postgraduate, so term is very, very important.
Incision is made.
So incision is made, yes, sir. Incision is made at the mid epigastrium to the below the from mid epigastrium to below 5 centimeters of the umbilicus.
Okay. You will modify according to your growth and accessibility. Definitely, to begin with, this incision is sufficient. Okay.
So then skin, subcutaneous tissue, linea alba.
No. You entered in the abdomen now.
So then we'll explore the abdomen, exploration of the abdomen for the assessment of any metastasis, presence of any ascites, and any distant spread to the liver, omentum, pelvis. And then, sir, we'll look for the regional lymph node, sir, and then we'll assess for the resectability of the growth.
Now, this point is important. You have said that after the assessment of metastatic disease, irresectability of growth. How do you decide that this is irresectable, this is resectable?
Sir, if the growth is involves the posterior abdominal wall, ureter, gonadal vessels.
Try to understand. Irresectable is a term. Okay. There are some structure which can be sacrificed.
Yes.
If the growth is adherent to the posterior abdominal wall, psoas and others, it is not resectable. If it is to the gonadal vessels or to the ureter, it still is resectable. You can say that disease is advanced, but it's still try to understand. The question was, how do you assess resectability? And there are two terms. One is curative resection and one is palliative resection. Okay, so keep in mind that and then answer this question. How do you assess resectability?
Sir, if it involves the posterior abdominal wall, sir, then it will be
see the major structures we are concerned when we do the right hemicolectomy is duodenum, kidney, and ureter, right? Even this is attached to the invaded the psoas, you can resect, may not be R0 resection, but some part of the muscle. But whenever you have to resect the duodenum, you think twice because you may land in Whipple separation. Number two, if the part of the ureter is involved, you can easily anastomose or ureter can be transplanted like this if it is. But whenever you do the kidney with colon like hepatic flexure, you have to be cautious that the renal functions and other opposite kidney and all those things, because kidney is a very vital organ. So better to stop here, not to remove the kidney for right colon, and you have to go for the NaCRT or NaCT and then you assess. This is important, and also duodenum. So you have to mobilize the colon and then you assess. You cannot see that this is the fixed growth like this, because even it looks a fixed growth, the posterior, the retroperitoneum. Whenever you doing this thing mobilization, you can get the plane. This is the dictum of colon. So very, very low threshold for this thing. The operation should be abandoned. Okay, this should be in mind in all colonic cancers. All colonic cancers. This is important. Now start dissection. This is resectable growth. This is resectable growth in the cecum.
Then we'll extrise the small gut to the left for ease of the dissection. So then we'll do the mobilization of right colon, cecum ascending colon. Cecum and ascending colon, sir, retracted medially, and the peritoneum is inside along the white line of Told. At the paracolic gutter.
At which point you start nicking the peritoneum? As you said that you medially retract the cecum and ascending colon, that means you pull the cecum and ascending colon medially, and then at which point you nick the peritoneum and then start the section. Yes, definitely. White line of Told is the line.
Sir,
Okay, so whenever you pull the cecum, when you go start dissection from the lateral side, you just pull the cecum and ileocecal junction medially, so that there is a string-like thing of the peritoneum which attaches the lateral peritoneum to the cecum. That is the area where you nick, because this is the almost dissected peritoneum. And when your plan is to do the mobilization from medial, same thing happens. You pull the ileocecal junction to laterally, and so there is a cord-like structure and the mesentery, and in the cord-like structure, the ileocolic vessels are there. So you start nicking there. So these are the two different things. Every time you have to pull either medially or laterally. Now you nick the peritoneum first, then you dissect and go upwards.
Yes, sir.
Okay. So you are going upwards. What are the points here? Very important point here you have to remember. What structure you first encounter when you dissect the peritoneum, mobilize the colon?
Sir, we'll encounter, sir, right ureter.
No. Right ureter is far behind. First structure, important structure, which you want to preserve.
To incise the peritoneum from cecum up to the hepatic flexure. Okay.
Yes, sir.
From below upwards, what are the important structure you will see? Most of the time, ureter is not visible unless you go very deep. Why you go so deep? Gonadal vessel. The first thing you encounter the gonadal vessel, and you try to preserve the gonadal vessel. And your plane of dissection or mobilization is, if you stay above the gonadal vessel, you will never see the ureter even. So you will only see in a thin patient that the ureter is visible under some the adipose tissue layers.
There is a fascial layer. You
Yes.
may be above this fascial layer, so that ureter is behind that fascial layer.
Yes. So
You
will
need
not
bring the genodas fascia. Even in the kidney, you just remain outside the genodas fascia.
Yeah,
And
that is your idea. Don't go deep. Don't go away from the colon. Stay near colon. Stay near colon. This is very important.
Yes, sir.
So you go up and up to whenever you reach the gerotas fascia. You don't have to dissect the gerotas fascia. You stay above the gerotas. But then, what is the important thing you encounter? Important organ, structure.
Near the hepatic flexure, what comes?
Sir, duodenum, sir.
Duodenum and medial to duodenum, another structure comes in the C loop.
Sir, pancreas, sir. Head of the
Yes. Head of pancreas. Yes.
So how much you dissect or mobilize the colon medially here at the hepatic flexure?
Sir, we'll mobilize the.
He said growth in the cecum.
Yes, sir.
If growth in the cecum, how far should be the distal line of resection?
Sir, middle.
You say the standard hemicolectomy, right? Standard extension of right hemicolectomy.
Sir, right third of the transverse colon, sir. In such a simple right hemicolectomy, sir. Sir, if in extended.
Vessel wise, because we are nowadays we are concerned about the vessel and the lymph node clearance. Unless we detect the vessel and clears the section, they clear the lymph nodes up to the origin of the vessel.
In the transverse colon, which vessel you take?
Which vessel you take?
Sir, in simple, sir, in cecal growth, sir, will take the right branch of middle colic, sir.
Right branch of middle colic. So you have to see the middle colic artery. So you have to dissect medially up to the almost third part of the duodenum to see that the middle colic is crossing duodenum. This is your limit of dissection. And if you do dissection up to that, then automatically your dissection is total mesocolic dissection. Okay, total mesocolic. That means CME, the central mesocolic excision, or like that. So remember, middle colic you have to see trunk, and then you ligate the right branch of the middle colic. This is one. And number two, for this, one point you have to remember that whenever you mobilize the colon, sometimes it happens that you are so busy with the mobilization, you will distort the anatomy. So if any doubt, the reposition of the colon in its original position, and then you confirm, then again you start mobilization. This is very important, because many a times the malignancy shortens the right colon and poses the difficulty in identifying structures, right? And the two important vessels which we ligate in right hemicolectomy.
Sir, ileocolic vessels and sir, right colic vessels. Sir.
So how to go their origin? You have to ligate at their near origin, huh?
Sir.
Which they are, or these two, right colic and ileocolic, originates from?
Sir, originates from superior mesenteric arteries.
So how to reach there?
Sir, we have to, sir, retract the right colon to the left, and we have to see, look for the vessels with the transluminant against the light, sir.
How do you tent the ileocolic artery?
Yes,
you can make the ileocolic artery tented. How do you do that? And then that is the line where you start incising the mesentery, because this is now a new concept of total mesocolic excision. So you have to incise the mesentery along this tented vessel. How do you tent the ileocolic artery? You pull the right colon down and out.
Yes.
Okay, that will tent the ileocolic artery. And by this, you incise the mesentery along the ileocolic artery and reach the point where it is the continuation of supramesenteric artery. Okay.
Yes.
Now tell me, cecal cancer, how much terminal ileum will remove, and hepatic flexure cancer, how much terminal ileum will remove?
Sir, for cecal, sir, we have to take, sir, 10 to 15 centimeter of terminal ileum, sir.
You have to take fixed. You cannot take 10 to 15. You say 15.
Yes.
Why do you say 10 for cecal growth? For cecal growth, a little more. Hepatic flexure growth, 10 is good enough.
See the new concept nowadays. Every guidelines says that, because as the terminal ileum is a very important structure, because most of the nutrient they are absorbed in the terminal ileum. So unless this is cecal growth, you only remove only 2 to 3 centimeter only of the terminal ileum. And cecal growth even not 15 centimeter, only 10 centimeter. This is the now a guidelines, because the terminal ileum is a very important structure. You know, the vitamin B12 and all those important nutrients are absorbed in terminal ileum. So as much as possible, because the basic principle of colonic malignancy, you know that the proximal and distal is 5 to 7 centimeter margin is enough. 5 to 7 centimeter margin. So if this ascending colon growth or hepatic flexure to 5 to 7 centimeter margin means up to cecum. So 2 to 3 centimeter ileum is enough, good enough, right?
Yes, sir.
This is the basic concept of 5 to 7 centimeter both margins. So now you ligate the both vessels. Have you done or seen the right hemicolectomy of your own?
Sir, I have seen one, sir.
You have seen once, okay. So many a times we could not find the right colic artery, because many times it's absent.
Yes,
many
sir.
times it's absent.
Yes,
Okay. And the thing is that ileocolic has got another branch. So we may miss the right colic. We can't ligate the both branches of ileocolic and thought that the right colic we have written, but that is not important. Right colic, whatever major vessel coming through the mesentery to the colon, we have to dissect to its origin, like it, right?
Yes,
and definitely the right branch of the middle colic is important vessel. It is almost never absent, or also ileocolic is almost never absent, right? So these are the two major vessels, and right colic you can get, you may not. So you remove the colon and ileum, and then it comes to anastomosis. What is your method?
Another thing is right behind. Nitesh, as you take the arteries close to the origin, what other important structure you need to take to the specimen?
sir. We have to take, sir, while dissecting, vessels, sir. We will, sir, along with that, the sir lymph node is also been taken.
So you have
And,
to
sir,
take care that you are taking also the lymph nodes along with this main vessels.
yes,
And
sir.
then you have to go up to the root of the supramesenteric artery to
Yes,
take
sir.
the central nodes.
Yes, sir.
Okay.
We have to take, yes,
And
sir.
you have not said that step of taking the greater momentum with the specimen. Because once you start the operation, you should take the greater momentum from where?
Sir, we have to take the greater momentum below the greater curvature of stomach.
The operation start near the stomach, below the gastrobilic arcade. Yeah.
Yes, preserving the gastroepiploic arcade, sir.
Yes.
Yes, gastrocolic momentum you have to take with the specimen, and the whole mesentery up to the origin of the vessel you have to take. And whenever you take the whole mesentery along with the vessels, automatically all the lymph node and lymphatics comes in your
So you
specimen.
have to take care that you are taking the lymph nodes also.
Yes.
Yes, sir.
Okay. You have now resected. Fine.
So what is your intention of removing lymph node? How much lymph node you want for your satisfaction? What is
sir,
the optimum harvest?
Or only resection?
Optimum harvest of number of lymph nodes in a colon cancer in general.
Sir,
sir, 12.
12, sir.
12 lymph node you have to harvest. Otherwise, your staging will not be completed. If you remove less than 12 number, the pathologist will write that NX. Right. So this is the important thing. At least 12 lymph nodes you have to remove along with your specimen. Okay. So how to anastomosis?
Sir,
first how to resect the colon, that is transverse colon, how to resect the ileum.
Sir, sir, we have to resect the ileum, terminal ileum, and the transverse colon by applying the 2 pair of intestinal occlusive clamp, and sir, by using cutting diathermy will transect the ileum and the transverse colon.
Nowadays, if you are not doing operation in a very rural area, most of the people, they prefer the linear stapler because of contamination. But whatever method you adopt, whatever process you have a method you take for these things clamp, there is some leak. So better if you have these linear stapler, then remove this thing colon and ileum with linear stapler. Right. Now anastomosis.
Sir,
What is your preference?
Sir, sir, either sir end-to-end anastomosis or side-to-side anastomosis can be done, sir. Either in the 2-layer close suture or 2-layer technique or single-layer technique, sir.
Yes.
You answer one. You answer one. What you have seen or what is the standard recommendation?
No, he has seen only one case, sir. How can?
Yes. One case was done. Yes.
What you have seen? What you have seen in your only one case? Okay, not an issue. But you have seen side to side, end to end, or end to side. There are three way of doing this.
End to end, sir.
End to end.
Yes.
Usually end to end are very infrequently done. Very few surgeons they prefer. Why end to end anastomosis is not preferred by most of the surgeons?
Sir, the diameter of
Yes.
the colon and the ileum is sir
Doesn't match.
doesn't match.
Moreover, mostly the surgeons are concerned about the vascularity. You don't know the marginal vessels. You are keeping the marginal vessels whenever you do the end-to-end anastomosis. So better to do anastomosis 1 centimeter away from the cut margin so that you are sure that the vascularity will be good. This is two important things. One is the disparity of the lumen, and another is the marginal vessel vascularity to the cut colon and cut ileum margin, right? So better to do the side to side anastomosis.
And if you fire a linear cutter, your both ends are closed.
Yes.
If you are firing a linear cutter, the ileum is closed, the transverse is also closed. So to open, you have to again open up this stapler line. It's not required. You keep side by side and do a side to side anastomosis.
This is called double stapling technique. You do the anastomosis with one stapler, and the open margin of the two this colon and again you close by another stapler. The double stapling technique. This is rather safer than hand sewn, because hand sewn there is subjective variation. Number one. Number two, you don't know your bite. The gap between the two bites are equal, and you don't know the tension of the sutures you are doing, and you don't know even the tissue hypoxia or like that, because in fact first 48 hours the suture or staplers, they keep the anastomosis, then the healing starts, right? Yes, so this is very important. Nowadays most of the surgeons, they prefer staplers, and not available, that is another issue. So you have to say standard techniques, right? So now tell me, what are the common complications of right hemicolectomy? Sir, before complication, we now do the close the abdomen, and then we discuss this thing.
What about mesentery gap?
Yes.
You have a small guard mesentery and the transverse colon mesentery. Do you keep it open?
No, sir. It has to be closed.
Why?
Sir.
Why you need to close it?
Sir, because sir.
What can happen if you keep this gap between these two mesentery? Chance of?
Sir,
yes.
Herniation.
Again, this is the newer concept coming. Even if you read the American Colorectal Association of Surgeons guidelines, recent published guidelines, 2021 and 22. So they say that this is surgeons preferable. Usually we follow that small gap should be closed, large gap can be kept open. Because large gap, the bowel is not obstructed, but small gap, yes, there is chance of obstruction, right? So this is the nowadays is followed, but still they say that it is a surgeon's option.
In the exam, it is better to say you will close the gap.
No, if he can quote from this ACRCS guidelines, because it is standardized guidelines, no? From guidelines they can quote. Just that this is a surgeon preference. Okay.
Because laparoscopy, they don't do it. In laparoscopy, they don't close the gap.
Yeah. So, so they don't close the gap, no?
Yes. Laparoscopy is an exercise. Why did they do it?
So it is written in ACRCS manual, the latest one. Okay. So after closing the mesenteric gap, what you will see before closing the abdomen?
Sir, we have to see any bleeding there.
Yes, very important. Particularly rectoperitoneal bleeding and the middle colic vein injury and the gastroepiploic vein injury. These are very common. They're very common. So you
What
have to
about
check
testing the
yourself.
anastomosis? What about testing the anastomosis, whether they have done a good anastomosis or not? Any test?
Nowadays, recent.
Sir, we have to take sir, normal saline in the bowel, and we can keep the
Also
anastomosis.
inside the bowel. How can you take? Socho bhaiya.
Sir,
You occlude the transverse colon, and milk the ileum, so that this gas comes to the site of anastomosis, and pour saline in the abdomen and
sir.
see whether the bubbling comes. Ideally, the anastomosis should be watertight and airtight.
Yes, sir.
It can test it on table.
Nowadays, what is the method of seeing the anastomosis integrity? Nowadays, the new thing has come.
Any new gadget which can show you the vascularity in the margin of the anastomosis?
Sir,
Shown in the
ICG,
conference, yeah.
you heard of ICG?
sir, endosign in green, sir.
Yes.
Fluorescence.
Yes,
ICG fluorescence, if you use a camera, there is a special camera.
Yes.
Okay, that can be used for open also. And laparoscopy also, you can use this ICG mode. Okay, that can show you the vascularity at the end of the anastomosis. So you find the vascularity is not there, that means it's going to leak. Okay, so you can use the ICG fluorescence.
They do usually before anastomosis, they see the marginal vascularity and they start the anastomosis. And after anastomosis also they do this thing because it is an IV injection and they see the distant camera. Okay, so you close the abdomen with drain or without drain?
Sir, with drain, sir.
A good right hemicolectomy without any risk factors like aging, low albumin like this. Like most of the surgeons, they don't prefer draining this thing. But if you doubt, yes, you give drain. And most of the surgeons who are not confident about their anastomosis and the growth, because we usually get our patients, not in Western population, our patients, very sick patients, malnourished patients, still we have to do so we usually routinely give drains. On the right, our patient population, good patient we do not get.
Yeah. So if you follow ERAS protocol, ERAS protocol says that drain is not required. Otherwise, most of us put a drain. You can say, we'll put a drain.
Because right hemicolectomy, you can omit drain. Because here is vascularity is not in doubt. But in left hemicolectomy at rectal case, the vascularity is some doubtful. So most of the people, they give drain in left colectomy like this. Right. So you close the abdomen. Now, tell us, when you send this specimen to the pathologist, what are the tests you require? This is very important in modern era. First, you definitely write the histopathology of the specimen. Then, what are the important thing you will write? Unless you mention the pathologists don't comment on those things.
Apart from HP report, anything else is required for planning subsequent treatment?
Sir, IHC.
What I see. It's a blanket comment. Blanket comment we don't want from postgraduate students. Never.
You see, the coronary carcinoma treatment has changed. The adjuvant treatment has undergone a massive change, and these are all based on the some
auxiliary findings. The auxiliary findings. Yes.
So you look for MSI. You look for some genetic mutations.
Yes.
Because we are the markers for subsequent treatment also. When the patient comes for relapse or a metastatic disease, these are all important.
What marker, sir, has said, what marker you want to do in colorectal carcinoma? Have you heard MSI or MMR?
Yes, sir.
Huh?
Yes, sir.
Have you heard that?
Yes, sir.
So how do you interpret MSI and MMR? That means MSI high is good or bad, MMR good, high is good or bad. These two you have to know.
High is
then another genetic analysis, KRAS gene mutation analysis is also an important factor for planning adjuvant treatment.
Sir, primary colonic cancer, KRAS usually not done. Usually not done. Recurrent and metastatic cancer, yes, these are done. The primary only MMR and MSI is important. So when MSI is high, MSI-H, it is good, the good prognosis. And if your stage 2 cancer is MSH high, you don't need to the chemotherapy. But when it's deficient, yes. Oppositely, MMR, when it's proficient, this is a risk factor. So you have to give chemotherapy. When deficient, then you don't need. These are the two marker points. Otherwise, you know that poorly differentiated adenocarcinoma and there is a lymphovascular invasion or the
invasion.
Yes, and the lymph node harvest is less than. Maybe you have removed 9 lymph nodes, all are negative, still they have to do this thing. These are the points you have to remember.
And lymph node positive disease.
Better you read the NCCN either guideline or you read for the malignancy this MD Anderson clinic, that book. That book is very, very important and very comprehensive. You can remember. Comprehensive book you have to read for the exam. And if you quote from these two areas, nobody can challenge you. Right? And now the complications of right hemicolectomy.
Sir, complications are, sir, anastomotic leak, then sir, wound infection, hemorrhage, then sir,
usually if you before closing the abdomen, if you are vigilant, postoperative hemorrhage is not an issue for right hemicolectomy. Yes, two are things: wound infection and anastomotic leak. These are the most bothersome issue in any colorectal operations. So anastomotic leak, when it occurs, usually.
Sir,
what is the most important factor for anastomotic leak? Just
yes,
number on if you say. Most important factor for anastomotic leak is what?
Sir, hypovolemia.
Huh? No, surgeon or the patient? Who is the factor? Most important is the surgeon. Because most of the time it leak occur because of the technical problem. And then patient factors are all there, agreed. But it is said that the surgeon's technique is one of the most important factor for leakage. If you do under a very tight suturing, if you are anastomosing a avascular end, so they are the very high risk factors. And then now you talk of other factors.
See, the anastomotic leak, if you don't know, I'm answering you. The most of the time, the anastomotic leak occurs during the 3rd to 5th day. Because first 48 hours, as I said previously, it will take care of the either suture or your stapler. So if within 48 hours leak occurs, then the surgeon is at fault. Definitely faulty technique, faulty application of stapler, faulty suture, choice of suture, and the techniques, all these things. And third, between the leak between the 3rd and 5th, there are these subjective factors of the patients, like hypotensions, like low albumin, and the other conditions like low anemia and all those things, and even aging. So these are the factors. Usually the leak occurs, manifests between 3rd and 5th days usually. So how do I diagnose that there is a leak? This is very important. You have to diagnose very, very early.
Sir, anastomotic leak will lead to, peritonitis, and signs of signs and symptoms of peritonitis may develop. So we have to take.
Will leak always cause peritonitis, or it can be a controlled leak also?
Yes, localized leak also, but still you can diagnose.
Sir, Sir, control leak, sir. Sir, will look for the.
What happened? Leak has occurred. It may cause a local abscess, and
Yes.
just drain is showing some fecal matter. Rest of the abdomen is not bad. Is not rigid, or patient is not having generalized pain abdomen and not generalized tenderness. So it can be a leak which is localized and coming through the drain. It's a localized leak. And second possibility, yes, there is widespread spreading of this content and causing.
Frank peritonitis. See, frank peritonitis is easy to diagnose. So we have to be vigilant for 5 to 7 days in any colorectal operations, because the leak is a very bad thing for the patient prognosis. So now you have to always examine the patient and look minutely for the features of SARS, because the first sign of leak is the features of either tachy or temperature or some breathing problem like this. These are the minor feature of the leak. Then your abdominal sign may come, and if you are lucky, then your drain will show that. It's the straightforward issue. Drain fluid looks like fecal matter. That is very easy to diagnose. The other, drain is not functioning, abdominal is mildly distended. So what is your preferred investigation when you suspect there is leak?
Sir, preferred. Sir, CT
Suspect
abdomen.
leak. That means your drain is not showing anything, but mildly distended abdomen, some features of SARS, tachy, temperature.
Yes, you're right. CT abdomen is the standard of care.
Why not
Ultrasound
ultrasonography?
often misses small collection.
Why not ultrasonography?
Sir, the small collection will be like.
No, because most of the time the gut is distended, there is gaseous, so the ultrasonography is not so pinpoint the collections, and this interloop, particularly interloop collection, is very important to diagnose. Okay, so CT scan is ideal, right? And then what you'll do?
Sir, if we'll do, sir, a re-laparotomy for the patient. If he suspects the anastomotic leak.
And after laparotomy, what you will do?
Sir, we'll do the stoma, sir.
Stoma. That means the anastomosis you will take outside to stoma, or you just do a proximal diverting stoma?
Sir, leak is there, sir. Then both the stoma will be, sir, like.
Yes, you can have two approaches. Both approach you can take. If you see there is a leak, is very less than 30% or like that, you can keep that leak there and just do a diverting stoma. But if the wide open anastomosis, then you have to do both things out.
You can take the whole stoma out, or you can do a Hartmann's-like procedure. If the patient is bad, you cannot bring it out. Close the colonic stump and then bring this end ileostomy. So you can. That depends on the patient status and the
condition also.
Yeah.
Because transverse colon externalization is a bit difficult thing than the left colon. It's not mobile. It is not very. It is almost fixed structure, not transverse colon. That is the thing.
Okay. There are two comments, Dr. Basu. Dr.
Yes.
Boshak has said resectability is judged by CT scan. Dr. Boshak, CT scan is a good investigation. I agree, but sometimes CT scan may not correlate the exact operative finding. So final resectability is judged on table. CT scan may show gross invasion. We will not operate. We will give the patient neoadjuvant. But even the CT scan shows resectable, there may be situations that during operation you find that the growth has invaded the duodenum, because minor invasion cannot be diagnosed by CT scan. Agreed. And Dr. Sumantade has commented that it is a routine practice to close the gap even during laparoscopy, and that is the standard guideline. But Dr. Basu has said the guideline, if the gap is wide, you may avoid closing the gap. Yes. But small gap are notorious because something goes inside it may get strangulated. So small gap may be closed, large gap may be just left as such. It does not cause much of problems because not all people are closing this mesentery gap nowadays.
No, my comment to Sumanto is, dear Sumanto, is that it is surgeon's preference as it is written in the book.
Okay, sir. Okay.
So
No,
Sumanto,
actually, sir was telling that in laparoscopy we do not close the mesenterico-mesocolic
okay.
window even it is closed, but we always try to close the mesenteric-mesocolic
Yes.
window. I do it by laparoscopy, so I always close the mesenterico-mesocolic defect. If it is small enough, if it is large gap, I leave it behind. But most of the cases I close it, sir.
Yeah. Because I see most of the surgeon, even doing a gastric bypass also, they don't close this gap between the small gut because they say nothing happens.
So surgeon's preference. Anyway, Sumanto, I love your videos.
Thank you so much. Thank you so much. Thank you with your blessings.
Okay.
So Makanda, apart from this detailed discussion, I don't think that we should again show any.
Just a brief overview. We can just give the 2, 3, 5 minutes. Just 5 minutes.
No new thing. All everything I have said that is written.
Your approach. 5 minutes. Just 5 minutes.
Okay. Let us share
Ali,
this.
they should understand what should be the standard approach. Just 5 minutes. Everything has been discussed. Yes, I agree.
So the key points are like that. Am I audible? And my screen
is screen audible.
So prepare the patient properly before operation. Mechanical bowel preparation with oral antibiotics, definitely only mechanical bowel preparation is not preferred. Plan the incision so as to yield the optimal exposure. Use Turnbull no-touch technique when possible. Yes, when possible. As you know, what is Turnbull technique, that you don't mobilize the cancer itself. You completely mobilize the segment to be resected so that the surgeons can obtain good clearance as well as accomplish a tension-free anastomosis. It's very important. You have to mobilize so that tension-free anastomosis is achieved and achieve adequate cancer clearance, both the resected margins and lymphatic fields. Already we'll discuss the resected, what is the optimal resection margins and optimal resection lymphatic fields. Ensure an adequate blood supply to the segments involved with anastomosis and achieve good and secure abdominal closure to facilitate early ambulation. As you know that nowadays the EHS guideline always said that how to close the abdominal wound, the stitch, the suture preference, the gap between the two stitches, both are clearly explained. So pre-procedural planning, as we already discussed, Nichols Condon regimen. Choice of incision, this thing midline or right paramedian. Most of the surgeons, they prefer right midline. Very few surgeons, they do with right paramedian. People say that right paramedian is a less incisional hernia. But Sumanto will comment on that. I don't know. Determination of the extent of the section, location of the tumor is very important. The tumor is in cecum. I already discussed that 10 centimeter margin of the terminal ileum is required. However, if the tumor is in ascending colon, only the few centimeters of the ileum required as margin, because terminal ileum is a very important organ. The line of resection should extend to the right side of the transverse colon at the level of right branch of the middle colic vessel. This is very important. So we have to dissect, mobilize the colon up to the duodenum where it crosses by the middle colic vessel. To ensure the proper lymph node harvesting, the right colic and the ileocolic vessels are taken at their origin. Omental attachment to the colon are generally removed with the specimen along with the lymph node. So mobilization, the right colon is mobilized. This CD where we start the dissection in open right hemicolectomy. So you pull the ileocecum in the medial side and separating the terminal ileocecum from the rectoperitoneum structures. The ureter and the gonadal vessels are the most important of these structures. And if you keep your dissection plates above this gonadal vessels, then you should not see the ureter and injure the ureter. This is the dictum of the dissection or mobilization. Okay. And separation is accomplished by the incising peritoneal attachment to these structures laterally and rotating the cecum anterior and medial. So as you go above, you will do this maneuver. So more mobilization. During this dissection, proper care must be taken to identify and posteriorly displace the gonadal vessel and ureter. The attachment of the cecum and terminal bowel are incised in an inferior to superior direction towards the junction of third and fourth part of the duodenum. As I said previously also, at least third part of the duodenum you have to expose to see the middle colic vessels. The mobilization of the ileocolic vessel is complete once the middle colic artery is identified where it crosses the duodenum. The exposure of the hepatic flexure is completed with the mid-transverse colon retracted inferiorly. See, there is two ways. Some surgeons go from the hepatic flexure entered into the gastrocolic omentum, and some surgeons, they entered the gastrocolic omentum, then comes laterally to meet this hepatic flexure point. So these two ways you can dissect whatever you comfortable. But remember, be cautious here. During mobilization, you don't injure middle colic vein. This is one structure usually we injure, or gastric veins. These are the two structures you have to remember. So the exposure of hepatic flexure is completed with the mid-transverse colon retracted inferiorly. The thin plane between the mesocolon and the gastrocolic ligament can be developed bluntly and dissected to complete the flexure. Yes, sharp and blunt both dissection is acceptable. So now we are, let's see, the whole entire right colon is with the ileum is medially retracted. So everything is cleared in our view. So now the gentle traction of the transverse mesocolon to mobilize the proximal part of the transverse colon. Perform this maneuver with a gentle touch to avoid the avulsing the branch of middle colic vein from this origin. Next, retract the right colon superiorly and medially to expose the anterior edge of the duodenum and the head of the pancreas. So release of these filmy attachment is the last remaining step of dissection. So if you dissect like this, automatically total mesocolic excision is done. Incise the avascular area between the ileocolic artery and right branch of the middle colic artery to the base of the ileocolic vessels at about the level where it crosses the lateral or inferior edge of the duodenum. Incise the peritoneum, overlying the ileocolic vessels, and doubly ligate and divide the vessels. Now we can use the vascular clip also. Sorry. So this is the total dissection and total mobilization of the ileocolon, and you can see the all the vessels and also the part of the head of the pancreas you can see. So divide the marginal branches of the ileum, thus preparing the proximal line of dissection. Divide the right colic artery if necessary. If necessary means sometimes it is absent, and the right branch of the middle colic artery. Finally, clear the distal bowel margin of fat and prepare for anastomosis. Yes, clearing of the distal margin of fat is important, particularly when you do the stapled anastomosis. The staple anastomosis, two fringes of a disposable linear cutting stapler, as we see, as we have discussed. Hand-sewn anastomosis also end-to-end, side to side, end to side. But better when you do a hand-sewn, better to prefer side to side. The mesenteric defect can be closed or left open depending on the surgeon's preference. It has been suggested that routine closure of the mesenteric defect may not be beneficial. So it is controversial, so leave it to the surgeon. And before closure, check the abdomen for adequate hemostasis and thoroughly irrigate with saline. Drains are used only for infection or abscess, and personal preference to use continuous sutures to close the facial layer and the interrupted ethylon stitches or skin staples to use the approximate the skin. Now, I think Ramakanda, no more thing to say.
Yes. Thank you very much. This is just a summary of the whole procedure. Very good. Okay. There is no question in the chat box for that.
Okay,
Thank
we
you,
will
Dr.
close.
Thank you.
Okay.
Thank you.
Thank you.
We closed at sharp 9. Yes.
Thank you.
Okay. Thank you very much.
Thank you.
Thank you.